Hello guys, welcome back to our channel. This is Ruby.
And I'm Bianca.
And we're going to be talking about the types of casts there is.
And the complications.
Okay, so there's two different types of casts. There's plaster casts and there's also fiberglass casts. So fiberglass casts are made up of polyurethane resin that are adaptable like plaster but way less. They are stronger, water resistant, and more durable than plaster. They are better to see through x-ray, and it dries as fast as 30 minutes. However, these casts are only used for simple fractures of upper and lower extremities, since they're harder to contour and mold. And they're less costly and mold better. However, they are heavier, not water resistant, and take longer to dry. A risk of plaster casts is exothermic reaction, which could cause serious burns.
So some complications are compartment syndrome. It's the most serious complication. It occurs when increased pressure within a confined space compromises blood flow and tissue perfusion. Ischemia and potentially irreversible damage can occur within a few hours if action is not taken. A tight or rigid cast that constricts the swollen limb is associated with this complication. So diagnosis of compartment syndrome is based on a clinical suspicion. It's an assessment of the 6 P's. It is pain, poikilothermia, which is the inability to regulate your body temperature, pallor, paresthesia, pulselessness, and paralysis, and also intracompartmental pressure. The earliest indicator of developing compartment syndrome is pain on passive stretch of other muscles in the immobilized limb. So the primary provider must be notified immediately. A delay in this diagnosis could increase the risk of failed treatment and even a possibility of amputation. If the complication is due to a cast, they can cut the cast in half longitudinally on one side or 2 parallel sides of the cast to release constriction and allow for inspection of the skin. The nurse assists in maintaining limb alignment, and the extremity must be elevated no higher than the heart to maintain arterial perfusion. So the second complication is pressure ulcers. Casts can put pressure on soft tissues, particularly if they are inappropriately applied, causing tissue anoxia and pressure ulcers. Lower extremity sites most susceptible are the heel, the dorsum of the foot, the head of the fibula, and the anterior surface of the patella. The main pressure sites on the upper extremities are located on the medial epicondyle of the humerus and the ulnar styloid. So if pressure necrosis occurs, the patient typically reports a very painful hot spot and tightness under the cast. Drainage may stain the cast and may emit an unpleasant odor. If discomfort does not occur, there still may be extensive loss of tissue and skin breakdown and tissue necrosis. To assess for pressure ulcer development, the primary provider may cut an opening in the cast and allow for inspection, access, and possible treatment. A dressing may be applied over the exposed skin, and the cutout portion of the cast is replaced and held in place by an elastic compression dressing or tape. This will prevent window edema from occurring, which is swelling or bulging of the underlying soft tissue through this opening. And the third complication is disuse syndrome. It's an immobilization in a cast or brace that can cause muscle atrophy and loss of strength and can place patients at risk for disuse syndrome, which is the deterioration of the body systems as a result of prescribed or unavoidable musculoskeletal inactivity. So to prevent this, the nurse instructs the patient to tense or contract the muscles without moving the underlying bone. Isometric exercises such as instructing the patient with leg or arm casts to split or push down the knee or make a fist helps reduce muscle atrophy and maintain strength. Muscle setting exercises, quadriceps and gluteal setting exercises are important, and maintaining muscles essential for walking. Isometric exercises should be performed hourly while the patient is awake.
Hello, thank you Bianca and Ruby for explaining to us the different types of casts and the different types of complications that can happen with casts. Right now, Yvette and I are going to be talking about nursing management and a nursing diagnosis with interventions to help prevent any complications. Go ahead, Yvette.
Okay, thank you. So for nursing management, there's before the CAST application, and we want to perform an assessment of the patient's general health, emotional status, and the understanding for the need of the device. And for the physical assessment, we want the part that's going to be immobilized. We want to assess the skin and the neurovascular status, including degree and location of swelling, bruising, and skin abrasions. For the skin lacerations and abrasions, they must be treated before the cast is applied. Asking patients and family what they know about the application and care of the cast can help determine the education that will be needed. For during the cast, assessments are performed at least every hour for the first 24 hours and every 1 to 4 hours thereafter to prevent neurovascular compromise related to edema. When assessing peripheral circulation, the nurse has to check the pulses as well as the cap refill and edema and color temperature of the skin. You have to know any weaknesses or paralysis of the injured body part. You have to monitor for numbness and tingling. To augment the flow of fluid, you want to elevate the extremity so that it's above the level of the heart during the first 24 to 48 hours post-application. That's just to enhance the arterial perfusion. If pain is due to the edema present, it can be controlled by elevating the body part, but if prescribed, ice bags or cold application devices are placed on each side of the cast, making sure not to indent or wet the cast. The nurse has to observe patient for signs of infection, which include unpleasant odor from the cast and any drainage staining the cast. Infection is more common from an open wound, but the moist and warm environment of a cast can be ideal conduit for infection. If infection progresses to the fever, the nurse must notify the primary provider and any of the signs occur. The nurse encourages the patient to move all fingers or toes hourly when awake to stimulate circulation. So specifically for immobilized upper extremity casts, if a cast is applied on arm, the unaffected arm will assume all upper extremity activities. The nurse suggests devices designed to aid one-handed activities. The patient may experience fatigue due to activities and weight of cast, so frequent rest periods are necessary. When patient is lying, the arm must be elevated so that each joint is positioned higher than the preceding proximal joint. For the lower extremities, casts on lower extremities include short leg casts extending to the knees or long leg casts extending to the groin. The patient's leg must be supported on pillows to the level of the heart to control the swelling, and you have to teach the patient to elevate immobilized leg when seated. Patients should assume a recumbent position several times a day to promote venous return. Gentle toe and ankle exercises that allow asymmetric contraction of muscles beneath the cast have shown to diminish edema by increasing the venous return. So specifically for body or spica casts, the difference between body and spica casts is that body casts are casts that encase the trunk of the body, and the spica casts they encase the portions of one or two extremities. Body casts are used to immobilize the spine. Hip spica casts, they treat various fractures of the hip or femur or to correct or maintain the correction of hip deformities after reduction or surgery. Both these casts stay in place for 4 to 6 weeks. The nurse must reassure the nurse must reassure the patient that several people will provide care during the application. Support for the injured area will be adequate. Patients in large casts may develop cast syndrome and can occur weeks or months after the cast has been applied. The patient tends to exhibit an acute anxiety reaction characterized by behavioral changes and autonomic responses like increase of respiratory rate, dilated pupils, increase of heart rate, and increase of blood pressure. The nurse must recognize anxiety reactions to provide an environment where patients can feel secure. Administer pain and anti-anxiety meds prior to the procedure. This can help to reduce the anxiety reaction. Patients with the body cast may develop a decreased GI motility and intestinal gases may accumulate. Patients exhibit abdominal distension, discomfort, nausea, vomiting, leading to poor food intake and weight loss. The patient is treated conservatively with decompression, like an NG tube connected to a suction, and IV fluid therapy until GI motility is restored. Caring for a patient with a body cast or spica cast at home can be very stressful for the caregiver. Therefore, it's essential that the nurses provide appropriate support and discharge education.
Okay, one nursing diagnosis applicable to the care of a patient with a cast would be risk for peripheral neurovascular dysfunction related to compression of cast. One outcome would be client will maintain tissue perfusion as evidenced by palpable pulses through our shift. So one intervention for this diagnosis, as Yvette mentioned beforehand, would be to assess capillary return and skin color. So another intervention would be to assess the entire length of injured extremity for swelling or edema. An increasing width of the injured extremity may suggest general tissue swelling or edema. One more intervention would be to evaluate the presence and quality of peripheral pulse distal to the injury. So a decreased or absent pulse may reflect vascular injury and necessitates immediate medical evaluation of circulatory status. Another intervention is to maintain elevation of injured extremities, and this just promotes venous drainage and decreases edema. And one last intervention would be to encourage the patient to routinely exercise digits and joints distal to the injury and to ambulate as soon as possible. So this is to enhance circulation and reduce pooling of blood, especially in the lower extremities.